Margery Johnson. I'm a child, adolescent, and young adult psychiatrist with Potomac Psychiatry. And today I'm going to be talking about treatment of anxiety in the individual with an autism spectrum disorder. This is an issue of increasing importance as we are, as you all know, are recognizing the concept of the spectrum and seeing many higher functioning individuals in adolescence and young adulthood. And the fact of the matter is children with autism grow up, and with better, earlier developmental treatment are often facing challenges later in childhood and adulthood as developmental stressors proceed. And as in pretty much everything in autism, the treatments are symptom focused. So targeting anxiety is often a very important component of treatment. There are a number of ways that autism spectrum and anxiety interact, and there's a very close interplay. And I'm going to discuss all of these aspects of anxiety in the autism spectrum. Intrinsic to autism is an aversion to changes in routine, an aversion to new things. And anxiety is certainly often a major factor in people's difficulty going out, meeting new people, having new experiences. Anxiety can underlie oppositional behavior in neurotypical children, and so why shouldn't it also be a factor for neuroatypical children? I think we all know that feeling in control and controlling your environment can reduce your anxiety. So very often oppositional behavior to control parents, teachers, other authority figures can reduce anxiety, so that sometimes treating the anxiety can reduce the oppositional behavior. Emotion dysregulation is also another prominent feature of individuals on the autism spectrum. Emotion dysregulation is the inability to manage the intensity or duration of negative emotions, like fear, sadness, or anger, and it can often lead to extremely difficult behaviors and can have a major impact on quality of life, quality of family life, and the child or teen's ability to function well socially, academically, or in the work world. So often anxiety can be a major component of emotion dysregulation, and treating the anxiety can sometimes help this significant problem. Social anxiety can manifest at numerous points in development. In grade school, the ability to be with peers, to do group activities or group games can be quite anxiety provoking. Obviously, with the onset of puberty and adolescence, social relations become much more complicated and much more difficult for just about everybody. So negotiating friendships and dealing with sexual feelings, sexual attraction, being able to appropriately deal with those feelings can be extremely difficult. Gender identity and gender dysphoria is increasingly being recognized as an issue for individuals on the autism spectrum. Gender dysphoria, or confusion about gender identity, appears to be more common in individuals on the autism spectrum than in the general population. And as individuals with autism receive more treatment, more special education, they're more likely to be able to go to college, leave home, find employment, and these are things that are anxiety provoking for everyone, but may be particularly challenging for the autistic individual. I often think of environmental anxiety is a factor for persons on the autism spectrum. Sensory sensitivities and difficulty tolerating certain environments can lead to anticipatory anxiety and further reluctance to go out and do things. We also see OCD-like behaviors in the autism spectrum, but there are some important distinctions. These are ritualistic or repetitive behaviors, but unlike OCD, they're less often related to unpleasant or obsessive thoughts. And what we talk about as obsessions in the individual on the autism spectrum are usually not unpleasant thoughts. They're more often obsessive interest in narrow, particular interests, and they may be peculiar, but they're usually a pleasant obsession. And unfortunately, the OCD-like behaviors in autism are less responsive to medication treatments and psychotherapies that are used for OCD. Treatment may involve medication or psychotherapy, and I'm going to discuss each one of these separately. The selective serotonin reuptake inhibitors, or SSRIs, are generally thought of as the first line of treatment for anxiety. Here I've listed the 6 SSRIs currently on the market, and FDA approval varies in terms of what conditions and what age groups are FDA approved. But the fact of the matter is that they are all used, and there is substantial evidence of their safety and efficacy in pretty much all age groups. There is some concern about Paxil, and it is used less frequently with children. The SSRIs, unfortunately, do not take effect immediately. Of course, we want relief immediately from anxiety, but it just doesn't work that way. You may see some initial improvement in about 2 weeks, and that's a very good prognostic indicator that there will ultimately be a good response. But a full response usually takes something in the range of 6 to 8 weeks, or even longer if there is extensive dose titration required. There are side effects, but fortunately none of the side effects involve major organ system damage or permanent effects. Very often, particularly in young children, people experience activation, which is a physical activation. The child might become kind of hyperactive and have difficulty falling asleep. This is sometimes confused with mood elevation, which is more like a hypomanic or manic state. Activation usually occurs pretty much immediately after starting an SSRI. Mood elevation tends to take several weeks. Gastrointestinal side effects are common, and this is most often a little bit of nausea, stomach ache. It's usually manageable, but it's occasionally a significant problem. Sometimes the SSRIs can cause insomnia or can make people feel a little bit sedated or lethargic. There have been reports of depression and suicidal ideation of young people on SSRIs that has resulted in a black box warning. This does appear to be a real side effect, but fortunately it is very rare. And if it does occur, you simply stop the antidepressant and try something else. An additional problem with the SSRIs is discontinuation syndrome, meaning if someone stops the medication abruptly, they can experience both physical and emotional side effects. And it is basically nobody needs to go through a discontinuation syndrome. You merely need to taper the medication. So this can be avoided. If SSRIs are either not effective or produce too many side effects, SNRIs, serotonin norepinephrine reuptake inhibitors, are also options. These are the 3 most commonly prescribed SNRIs. Duloxetine is the only one that has FDA approval for children, and there is considerable evidence of its safety and efficacy. So that is usually the one that is used in prepubertal children. Other SNRIs may be options for adolescents and adults. There are some other anti-anxiety medications. Buspirone is also serotonergic, and it's non-addictive, so that it can often be used in addition to an SSRI or an SNRI or on its own. Beta blockers are sometimes used. They do not address anxious thoughts, but they do address the physical symptoms of anxiety and even performance anxiety. So they're effective for the rapid heart rate, the sweaty palms, the dry mouth from anxiety. Benzodiazepines are sometimes used, but can be problematic. Young children often have a paradoxical response and become more agitated, and at high doses and used regularly, they can cause tolerance and dependence. So benzodiazepines are often reserved for very acute anxiety or for use on an as-needed basis. And finally, second-generation antipsychotics such as Abilify and Risperdal are sometimes used for severe anxiety, but they do have significant both short and long-term side effects. Psychotherapies are certainly very helpful in specifically addressing anxiety. Cognitive behavior therapy is basically based on facing your fears and doing it gradually. You start with the easy things and then gradually challenge yourself to face things that make you extremely anxious. Group therapy, particularly social skills groups, can be particularly effective. In group, you learn skills and then practice them with your peers. A young person talking to a middle-aged adult therapist isn't necessarily the best way to learn social skills for your peers. And supportive therapy may also be very helpful in dealing with whatever is the current stressor, whatever is the current challenge. And having a supportive, understanding relationship is obviously important. So finally, some just general thoughts about anxiety. Anxiety does tend to be chronic with periodic flares, often in response to a new developmental phase or a particular stressor. The impact of anxiety mostly relates to developing patterns of avoidance, that people can develop serious impairment in terms of social, academic, or work performance by avoiding things due to anxiety. And we basically just want everyone to live up to their potential and not be limited by anxiety when treatment is available.